Uh, Greetings from AIMS Devgar. Myself, I am Dr. Narsimha. Can you introduce yourself?
I am Dr. Shantanu Nath. We both are assistant professors in the Department of Psychiatry in AIMS Devgar.
So, on the occasion of World Suicide Prevention Day, that is 10th of September today, we would like to bring a short interview between both of us. The objective of this interview is to basically highlight what is the burden of suicide in India and also focusing on certain preventive aspects in terms of suicide. So, shall we start the interview, Dr. Shantanu?
Dr. Narsimha.
Yes. So, Dr. Shantanu, would you like to tell us what is the theme for today?
We all know that today is the World Suicide Prevention Day 2021. Now, this is a day that celebrates suicide prevention, that commemorates the prevention aspects of suicide. And each year we have a theme with respect to the Suicide Prevention Day. So the current year to 2021, the main theme is creating hope through action.
Okay. So, what does that mean? Can you give us?
Yeah. So this calls for a very inclusive and collaborative approach from all the stakeholders, like for example the sufferers of mental health issues, from chronic physical conditions, from physicians, not only psychiatrists, but encompassing other departments, starting from the grassroots physicians to physicians in catering to people in tertiary care centers, to government policy makers, to non-government organization centers and other centers like the judiciary and everything. So all the stakeholders, it is a collaborative approach to call them for a inclusive management to start an action such that we can prevent suicide for a better functioning of our society. We know that it has been decriminalized in current context in India as well, but that needs a collective responsibility and collective reporting, which will decrease stigma and a collective action.
Okay. So, Dr. Shantanu, you have commented about preventive aspects. So, is suicide a big problem in India? What does the statistics suggest?
Yeah, Dr. Narsimha, a very pertinent question indeed. If I am to be sure about it and I am to be true about it, it's really a great burning issue currently in India and also definitely in the whole world. Now, India we know is a subcontinent, a third world country. If we go by literature, the statistics, the burden of suicide from this subcontinent is around 18 to 20% of the contribution globally. So, if we say that 100 people die of suicide globally, then from India it would be around 18 to 20 people. So you can understand the magnanimity, the enormity of the condition. It has been studied and has been published in very well reputed journals of like the Lancet, that over a span of over a span of 20 years, from 1990 till 2016, 17 years to be precise, there has been a substantial increment in the rates of suicide in respect to gender and overall. Currently, it has been found that for females, obviously it has been found over countries and over periods in India, that females are more prone to die by suicide, to attempt suicide than males. It has been found that in that global burden of disease study in Lancet that got published in 2019, it showed that while for females it was 25% in 1990, in 2016 it increased to 36%. So you can understand the enormity of the condition. For males, it's a bit lower, it's around 18 to 90% in 1990, it increased to 25% in 2016. So this points to the increment, the rate of increment and the global burden that it subsumes. If we go by the Indian data, we have the the Crime Records Bureau, the NCRB, 2019, I think Dr. Narsimha, the last report came. It didn't came into 20 and 21. So around 1,39,000 people died by suicide. Now the catch is that we know that suicide in current context is not a crime, but still NCRB, the National Crime Records Bureau, is giving the statistics of it, and to date In Indian context, this is one of the most important source of suicide deaths in the country.
Okay. So, based on what you have told, the stats are quite alarming. The numbers have been increasing, and specific vulnerable population has been affected. So, what can we do actually to prevent this? What is the responsibility of an individual? What is the responsibility of the community? What is the responsibility of the policymakers to actually prevent these suicides?
A very pertinent context. It's not a responsibility only by us psychiatrists. Like as I've mentioned about the stakeholders, like everyone has to play a role, starting from physicians, starting from the grassroots physicians to tertiary care center physicians like us. Us means not psychiatrists, everyone, starting from cardiologists, like pulmonary medicine specialists, community health specialists, public health specialists, everyone. So this the management can be at the at the individual level. Individual level means support system should increase from individual level, early diagnosing starting from a primordial prevention and this primary prevention, like knowing and understanding those who are at risks of dying by suicide or verbalizing thing, understanding suicidal ideations, and if it has been understood to take them for proper care, that is very much important. Now, it doesn't mean that all suicides come with alarm. It might be very impulsive at times also. So, but there are graded assessments to understand those people, even vulnerable populations like those in orphanage homes, in prisons, in marginalized communities, they are at high risk. So we have to target wholeheartedly. This is in the individual level. If we go for a community level, this calls for a wholehearted action from all the community stakeholders. Like starting from, if we start from the basic grassroots level, like in a village, we have the panchayat system. Identifying those in that catchment area whom they are highly marginalized, who has got a higher risk factors, and seeking care for them. Those people who have been suffering from chronic physical diseases like rheumatoid arthritis, chronic diabetic nephropathy, and diabetic complications, chronic kidney disease, to understand them, to take them to proper care. Community level also encompasses the primary health centers. The community leaders are very important, even the religious leaders, they can also play a role, because we know India is quite a bit religious country. So it might so happen that people might listen to religious leaders to seek early care and everything. At the national and policy level, it calls for a wholehearted action, like stakeholders, like from the policy leaders, the leaders in judiciary system. Like we have till date, we know that Dr. Narasimha, like we have many laws that have come. One of the crucial was what came in 2014 was National Mental Health Policy, and that had actually called for a wholehearted action to prevent suicidal deaths. In 2016-17, we had the Mental Health Care Act that came after many years of the Mental Health Act in 1987. So this had done a major role in decriminalizing suicide. They have a clause in which suicide is now decriminalized. So if this is done at the policy level of this much magnanimity, then people who are harboring like suicidal deaths, they might come for care. The stigma regarding suicidal deaths will decrease, and they might come, we can have more reporting of data, and they can come for proper care. If it is criminalized, then we know that they would not come up, they would not speak up about their suicidal problems. Also, we have, in particular context, like we have the protection of the women domestic violence that came in 2005. Like we know that married females are at higher risk of dying by suicide. And so this law also gives empowerment to married females to report any type of domestic violence. And these are all the collective efforts that already the government of India has done. But this doesn't end here. It needs multiple, like collaboration with WHO and other international policymakers to make a wholehearted plan. Thus, we can plan for prevention of suicide.
Okay. So I also understand from your talk that there are certain group of people who are more vulnerable. So I would like to here focus on two vulnerable groups. One is adolescents, and more specific, the medical students. So are they at higher risk? Is there any evidence to support that adolescents and specifically medical students or doctors are at a higher risk of suicide?
That's an important point you touched, Dr. Narshima, actually. It has been, I cannot quote you the exact reference, but the Global Burden of Disease study, the suicide risk factor study, even the National Mental Health Survey, that is one of the widest, one of the biggest epidemiological study carried till date on mental health in 2016. The age group of 15 to 29, it has been found that suicide is one of the leading cause of death. I think it comes next to road traffic accident, if I'm not sure. And if I increase the range of further bit from 15 to 39 years of age, it is one of the most prominent cause of death, combined surpassing even deaths due to any other illnesses, even road traffic accident also. So, see, this is the adolescent group to early adulthood. So they are definitely at the highest risk of planning, having an idea, and dying by suicide. Medical students, another vulnerable issue that you have just touched. Literally, in Indian context, we know that studying medicine is quite a very coveted discipline amongst students, but quite stressful. Even like starting from the undergraduate level to the post-graduation level, then to enter into a professional job. So it's a huge amount of time, huge amount of stress. Like people who have poor coping skills, increased amount of burnout, and we have seen that the COVID time it has created a havoc in the medical fraternity. The people have to put in donning their PPE kits, and with that they have to work for hours. And with the thought that probably they might carry their infections home, they might themselves get infected. There are so many doctor deaths, like more than 1,000 deaths according to Indian Medical Association, if I'm not wrong. So definitely, these medical students and adolescents are a highly vulnerable group, and that has to be targeted.
So, pertinent to this question, in continuation, I would like to ask you as a part of the institute, the Department of Psychiatry at AIIMS Devgar. So, what do you think the steps that you can take to help the medical students and the medical faculty working here to help to improve their mental health and also to prevent these suicides? What do you think that we should be doing?
AIIMS Devgar is one of the prestigious institute that has come in one of the states in India, like Jharkhand, that had a wide gap of both treating physical illnesses and mental illnesses. Currently, we have around 70 faculty members, we have residents, and this third batch of undergraduate students are about to come. So we have around like 100 to 140, I think, MBBS students we have, and many people who are working day in and day out in this institution, though which started just 2 to 3 weeks back. Now, since we know that doctors and medical students, nursing personnels, nursing officers, all are at high risk because of the burden and everything. From a Department of Psychiatry initiative, like we cannot look back. It's definitely our collective effort that we can have. It can start from basic educating the other disciplines of doctors, even the medical students. Like they should have easy access to care. We can plan for something with proper intimation from the authority, proper help from support from the authority. We can plan to keep some gatekeepers. Like in hostels, we have around 140 students we have. It's not a very easy task to look for all of them to identify their mental health if they are at risk or they are about to enter into a risk factor or they are having some kind. See, suicide is a very abstract concept. We don't have a marker to understand this by seeing this type of markers in blood or something. So it can be camouflaged in overt behavior. So if we keep some gatekeepers, the students know that this is the person whom we can approach, whom we can at least go and talk for 10 to 15 minutes so that our concerns get heard by that faculty or by that resident, then it will be easier for us. See, coming to a clinic is a different issue, but if at least it might so happen that a 10 to 15 minutes talk across the table can be a better option to at least mitigate some of the risks of suicide. So that can be gatekeepers can one of the risks. It can be chosen from interested faculty members, residents, etc. Even student volunteers can be there. If some people who are forthcoming in helping their peer groups we can, those who have some degree of leadership qualities, we can at least choose them, and we can harness their like skills in identifying this. Coming from the faculties, doctors, residents, and nursing officers who are daily doing the service, it can be direct source to us. Like we can start IEC, information, education, and this communication type of methods, by which the department remains always open to all the faculties, all the nursing officers, and administrative people who are daily there serving the institute. So I think that can be one of the baby steps that we can take in identifying and giving some degree of service to people at risk or harboring an idea to die or something.
Yeah, so basically you have brought in an important point that we should actually improve the access to care through, for example, gatekeepers, providing IEC materials. How about improving the mental health well-being of the faculty?
Mental health well-being, definitely, like that's an important thing. Like the important mental health concerns with regards to the faculties is in response to burnout. It might so happen like now the numbers are swelling up, OPD numbers are swelling up, OPDs are going late, there can be a burnout. And so issue is that if some type of informal discussions can take place, like before we start our OPD daily, like normally it's not a very big group nowadays, we have 70 faculty, some resident nursing officers. If we can have a over the cup of coffee discussions, like some degree of faculty room discussions within the faculty rooms, we can at least try to understand what's going on in them, at what point of time they're actually getting snapped off with that burnout thing, that type of thing. So that all depends upon communication. Like this is the one thing that we can do at our level. It just can be over a cup of coffee while going in a car. It can be an informal discussion as of now.
So thank you, Dr. Shantanu, for your valuable inputs. Would you like to give any concluding comments?
Yeah, so this World Suicide Prevention Day 2021 should not let us sit in a chair, but definitely calls for a holistic action from both of us in the department, and also to all the stakeholders, all the people, all the discipline doctors, like from general medicine, general surgery, dermatology, cardiology, surgical oncology, surgery, everything. Like whenever one is encountering a patient who has at least got that courage to speak about having an idea to die, that should be asked, that should be given a year to understand what's going on in their mind. We as a department are open for everyone, not only for patients, for faculty members, for students and everyone. But we need to, at least from our side, we need to give us a hand, a year to listen to their problems. That I think would suffice as of now in our institute.
So thank you.